Welcome to Chest Pulse. I'm Dr. Doreen Addrizzo-Harris, Professor of Medicine at NYU Grossman School of Medicine and Director of the NYU Langone Health's Bronchiectasis and NTM Clinical and Translational Program. And joining me today is Senior Nurse Practitioner Amy Springer, who also works at the NYU Langone Health Bronchiectasis and NTM Program. Welcome, Amy.
Thank you so much for having me today.
So we have a lot on our agenda to discuss today. The focus is going to be treatment strategies for patients with a number of conditions. We're going to talk about patients with recalcitrant Mycobacterium avium complex pulmonary disease, patients with resistant Mycobacterium avium complex pulmonary disease, and patients with Mycobacterium abscessus pulmonary disease. So why don't we start talking, Amy, with about patients with recalcitrant MAC pulmonary disease. So I'll start by giving the definition. Patients who are treated for MAC who have persistent positive cultures by month 6 of a guideline-based treatment regimen are considered to have recalcitrant MAC pulmonary disease. We expect the majority of patients who are on treatment for MAC pulmonary disease to have converted their sputums by month 6. And as you know, the goal is for treatment after conversion to have at least 3 consecutive negative sputum cultures that stay negative for 1 year of therapy. So, Amy, what do we do with these patients who we may have put on 3 times a week or daily therapy with a standard guideline-based treatment when their cultures fail to convert?
So when we see patients who have recalcitrant MAC lung disease, there are a few things that we need to take into consideration. First, we need to confirm compliance and how they are taking the prescribed antibiotics. We want to be sure that they are taking everything we are prescribed and at the correct dosing as well. In addition to that, it is important to consider repeat antibiotic sensitivity testing in patients with recalcitrant MAC lung disease. We know that patients are often getting reinfected with new MAC species, so repeating the antibiotic sensitivity panel is something to think about at this time. There are a few treatment options we have for patients with recalcitrant MAC. If patients are on 3 times a week therapy, then we can change them to daily antibiotic therapy. We can also consider the addition of Arikayce, as it is FDA approved for treatment of recalcitrant MAC lung disease. In addition, we could consider the addition of clofazimine, and then depending on the severity of disease, whether there is progression on the CT chest scan or cavitary lung disease, we could consider the addition of IV amikacin at this time. The other thing to think about is considering putting your patient into a clinical trial that has inclusion criteria for patients with recalcitrant MAC lung disease. For example, currently our site is involved in a clinical trial using inhaled clofazimine, and there are other studies that will be opening up in the future on this topic.
Thank you, Amy. So again, usually you will not find out that your 6-month culture is positive to month 7 or 8. So you know your patients have been on therapy at least a full 6 months. We like to follow cultures in patients who are on treatment. About every 1 to 2 months is what we really love to get, if possible. This way we can tell when they are first converting and start our clocks from that time point. Amy, you mentioned something very important in patients with recalcitrant disease, and that is reinfection. We know these patients are continually getting reinfected. And since Mycobacterium avium complex holds a number of species, right? They may, and we don't subspeciate to the lower levels, they may have a Mycobacterium avium initially that we treat, and they could have gotten reinfected with a Mycobacterium intracellulare. So you really, we are not based on standard mycobacteriology lab procedures able to, at least at our institution, tell if they're getting reinfected when it's a MAC species. So again, looking at what they're doing in their hobbies and their daily life, reinforcing not to be exposed to heavy steam conditions that might be in hot tubs or steam rooms or long showers, hot showers in non-ventilated bathrooms. These are some of the things that we might be cautioning patients against. And then again, looking at other reasons that they might be getting reinfected. And one areas that we find to be very important is chronic aspiration. We talked about comorbidities in a prior podcast. So looking for underlying reflux, it may be asymptomatic. And if patients are having recurrent aspiration, they certainly can be reinfecting themselves. So starting out with a GI workup, as well as lifestyle changes of making sure that patients are not eating or drinking before going to bed, 2 to 3 hours before going to bed, may be some of the things that you would want to consider. And then the last thing we will do in a patient who is compliant with meds, but stays recalcitrant and does not convert after we may have looked at all of these other cofactors, is we might obtain serum drug levels in these patients, making sure that they are absorbing the azithromycin, the ethambutol, the rifampin or clofazimine that they may be on. And we'll look at those levels and then, if needed, adjust the dosing. I would highly consider doing this earlier in any patients who have underlying inflammatory bowel disease or have had resections of their GI tract, because those patients would be even a higher likelihood of having some sort of malabsorption. Okay, so that's really our toolbox for recalcitrant MAC. Now let's turn our discussion to resistant Mycobacterium avium complex pulmonary disease. Resistant disease is usually named macrolide resistant. So as we said, the guidelines now recommend getting antimicrobial sensitivity testing on all initial isolates in patients diagnosed with MAC pulmonary disease. And the two antibiotics that we will be focusing on when we get back that antimicrobial sensitivity panel are the macrolides. Usually testing is done to clarithromycin, sometimes also to azithromycin. Making sure patients are sensitive to the macrolides is key. As we know, that is our number one potent drug in the guideline-based regimen. The other antibiotic that you'll want to look at is amikacin. Often labs will give you a breakdown of intravenous amikacin and inhaled amikacin, as the MICs are different and often lower for the inhaled amikacin. And that would be very important to you when you're considering adding liposomal amikacin or Arikayce, or using intravenous amikacin. What do we know about macrolide resistant Mycobacterium avium complex? Well, we know that patients in that group do not do well. There is increased mortality in that group, and usually fairly rapid progression of disease. As we know, patients who have macrolide sensitive disease and have nodular disease have a very good outcome, with most patients and centers reaching 80% culture conversion rates. We know it's lower in cavitary disease, and sometimes drops as low as 40%. But when we look at macrolide resistant disease, studies have shown that using just the standard guideline regimen only gives you approximately 5% of the ability to culture convert them. So we know most of those patients will not improve and will not be cured and will progress. So what needs to be done in those patients Intravenous therapy is key. So patients with macrolide-resistant disease would need to be on IV amikacin, and those with localized disease that can be resected is extremely important to entertain that early in their care. We know that patients who have surgical resection and have IV amikacin, often for prolonged periods, more than 3 months, and have additional guideline-based meds such as ethambutol and rifampin and clofazimine added to their regimen, can reach 80% culture conversion rates, but that's only with the IV therapy and with surgical resection. So these are very, very severe patients, and we would recommend in this group referring them to a center that is experienced in dealing with macrolide resistance. The other point to note is the importance of avoiding monotherapy with either azithromycin or clarithromycin, and getting the word out not only to our pulmonary community, but to our internal medicine and primary care community. We know that unopposed monotherapy with macrolides can cause patients who have underlying MAC pulmonary disease to then convert to having macrolide resistant disease. And that is certainly not something that we want to iatrogenically do. So please avoid giving any of your patients who may have a URI or bronchitis azithromycin as the treatment for that. And we obviously stay away from that. Only use azithromycin when it is in combination with at least 2 other medications. So on this note, I want to just remind those who are tuning in that you're listening to Chest Pulse. And I'm Dr. Doreen Addrizzo-Harris, professor of medicine at NYU Grossman School of Medicine and director of the NYU Langone Health Bronchiectasis and NTM Clinical and Translational Program. And joining me today is senior nurse practitioner Amy Springer, who also works at our NYU Langone Health Bronchiectasis NTM program. The topic for today's discussion is recalcitrant, resistant MAC, and also M. abscessus. We have already completed our discussion on recalcitrant MAC and resistant MAC, and now we're going to be moving on to a discussion on Mycobacterium abscessus. Mycobacterium abscessus is defined as a rapid grower. The Mycobacterium species are broken down into 2 groups: slow growers, which Mycobacterium avium complex is housed in the slow growers group, and Mycobacterium abscessus is in the rapid growing group. I'm going to let Amy discuss with us how we look at Mycobacterium abscessus and what the importance is on subspeciation in this group. Amy?
When a patient is first referred for the treatment and management of Mycobacterium abscessus, there are 3 important things to know prior to initiating antibiotic therapy. First, we want to look at the subspecies of Mycobacterium abscessus, which include Mycobacterium abscessus, Bollettii, and Myceliense. Unfortunately, there is a lot of variability on what we can get back from particular labs, and many labs do not give us this information, unfortunately. Next, we also want to look at genetic analysis for gene analysis, which indicates if you are dealing with a macrolide resistant versus sensitive organism. M. abscessus and Bollettii both have a functional gene, which makes them macrolide resistant organisms, while M. abscessus Myceliense has a non-functional gene, making them a macrolide sensitive organism. Thus, Mycobacterium Myceliense is the easier one of the subspecies to treat.
And what do you do in your practice? Are you able to get subspeciation back from the NYU lab?
So at our facility, for the M. abscessus cultures, we have to send them out to National Jewish Health, and they provide the subspeciation, gene analysis, and also antibiotic sensitivity testing. We do want to be sure to get the antibiotic sensitivity testing on the M. abscessus organisms that we're sending, this is extremely important to send so you know which antibiotics can be effective in patients and who are going to be treated. It's important to request for us at National Jewish to request both a 3-day sensitivity test as well as a delayed 14-day sensitivity test. And while thinking of a drug regimen for these patients, it is important to note the patient's comorbidities and allergy profile, as this could make selection of antibiotic regimen difficult, as there are already a limited number of drugs that are available to treat the Mycobacterium abscessus infections.
Absolutely. And I want to get back to the point about knowing how long your lab incubates the culture before they read out the sensitivity testing. And that's very important for you to know if your lab is doing a 3-day or a 14-day. At the 3-day, you will not pick up acquired macrolide resistance. That takes a delayed incubation period. And at National Jewish, they're doing a 14-day. So you do pick up macrolide resistance. If you just looked at the sensitivity panel at 3 days, they still appear to be macrolide sensitive. So extremely, extremely important, not only in picking the regimen that you're going to use, but in being able to tell your patient what the actual outcomes are going to be. Culture conversion rate for patients with Mycobacterium macilliense, which is often macrolide sensitive, as you just said, is as good as MAC. Lung disease. So at 80% and sometimes even higher in series. Whereas those M. abscessus, particularly the most common one, M. abscessus, that is macrolide resistant, culture conversion rates are only in the 20 to 40% range. So again, very important to know which bug you're dealing with. It's also going to help you decide on how aggressive your antibiotic regimen is going to be. So I'll move into the next phase of making the decision. Once you've decided, or once you've gotten information back to tell you what type of Mycobacterium abscessus you have and whether or not it is macrolide sensitive or resistant, then you will make your decision on how long an intensive phase of therapy you will need to give versus a continuation phase. In Mycobacterium avium complex treatment, we don't start with an intensive phase that includes IV antibiotics in most patients. We usually just start them on 3-drug guideline-based regimen, azithromycin, ethambutol, and rifampin, and we continue that until they culture convert, and most patients will culture convert somewhere between 3 and 6 months. And then we continue the therapy for an additional year. So they have 1 year of culture negative treatment. In Mycobacterium abscessus disease, for both macrolide resistant and macrolide sensitive, we are going to start some sort of an intensive phase that includes IV antibiotics. We will take the most common case that we see here in the United States, which is Mycobacterium abscessus macrolide resistant. That is the most common and the most difficult to treat. An intensive phase in this group would include 2 to 3 IV antibiotics, plus usually 1 oral antibiotic. And in our 1 or 2 oral antibiotics. And in our clinics, we often go to using intravenous imipenem along with intravenous amikacin as our IV meds. Most species are also very sensitive to IV tigecycline, so that may be an option. Again, you're going to have to look at the patient's comorbidities, allergies, and ability to tolerate these meds. So a regimen may look like 3 IV antibiotics up front, daily IV imipenem, which is usually given twice a day, IV tigecycline, which is given once a day, and then a 3-time IV regimen of amikacin, coupled with, in our clinic, usually clofazimine. Again, most species are sensitive to clofazimine. There may be other drugs that you would be able to substitute, and a nice oral compound that is similar in efficacy to tigecycline is omadacycline. It is become FDA approved for different types of pneumonias, but is very effective in treating Mycobacterium abscessus. So if you are able to access omadacycline for a patient with insurance approval, you may end up having them on IV amikacin, IV imipenem. Another option, IV, if you don't use imipenem, is IV cefoxitin. Again, a large number of patients will have sensitivity to that. You will be using your sensitivity profile to help you choose these medications along with omadacycline and clofazimine. But whatever regimen you do choose, you will be doing the intensive therapy usually for at least 2 to 3 months. And it will all be based on improvement in your patient's symptoms and CAT scan, as well as the tolerability of them staying on the IV therapy. There may be patients who are responding, who have very severe disease, that you would continue therapy for even 6 months or 12 months intravenously, depending on how severe their disease is. Then you would move on to the continuation phase. And in the continuation phase, we like for macrolide-resistant M. abscessus to have a patient on 3 to 4 oral or inhaled drugs if possible. Very easy to go from IV amikacin to inhaled amikacin, inhaled liposomal amikacin, or Arikayce, if you can get that approved through the patient's insurance company. And we have had some success in that area. You can continue that with your omadacycline, with your clofazimine. Again, if you don't get approval for all of these, other options include some of the oxylinones. Right now, linezolid is the easiest oxylinone to get approved by insurance for these patients. And again, you'll use your sensitivity profile to look at the regimen and see. There are other drugs that are a bit less studied, but available and have some efficacy, such as bedaquiline might be another option in an appropriate patient. So you're going to have to monitor these patients with weekly bloods initially while they're on IV therapy. And then for some of the other common side effects that we talked about when you're using IV amikacin for MAC disease, you'll be wanting to do regular, at least monthly audiograms. You'll be wanting to do regular EKG monitoring, since a number of them have issues with QT prolongation. When you have a patient who has M. abscessus that has a macrolide sensitive species, then azithromycin is going to be part of your regimen up front. You may not need to use as many intravenous drugs or for as long if they're macrolide sensitive. Azithromycin can even be used in the macrolide resistant patients if you're using it for its anti-inflammatory effect to prevent them from having as frequent exacerbations. But we know that macrolide sensitive organisms, azithromycin should be used upfront, and the patient should be on a daily regimen. Often an oral regimen for them would look like azithromycin, Arikayce and clofazimine, or azithromycin, omadacycline and clofazimine, or azithromycin, Arikayce and omadacycline if you don't have access to clofazimine. I very much recommend referring patients with M. abscessus, particularly those with macrolide resistant M. abscessus, to a center that is experienced in dealing with Mycobacterium abscessus. And the other point that we don't want to forget, and we've brought this up prior, is that surgery is a key option for patients with Mycobacterium abscessus, particularly those with macrolide resistance. Very important if they have localized disease, we will move to surgery very early on. It is very important that you use an experienced surgeon who is experienced with doing resections in patients with mycobacterial disease. And the other point is that we might even do resections in patients with multilobar disease, particularly if they have resistant Mycobacterium abscessus, because we know the poor outcomes without surgery. And those multiple resections can be a stage where a patient can have a right middle lobectomy in month 1 and then recover over the next 8 weeks and then go back in for a lingulectomy if that is needed. Of course, preoperative assessment with pulmonary function testing, sometimes perfusion scans have to be performed to be sure that patients can tolerate multi-lobe resections, but it is definitely something that should be considered in patients with Mycobacterium abscessus, macrolide, that is macrolide resistant. Amy, do you want to just, before we close, just give a little bit about how you follow these patients as far as, how frequently are you seeing them and having to speak with them? And what is the kind of the burden on the providers, as far as need to monitor these patients?
Yes, so patients on treatment for Mycobacterium abscessus, as you said, do require frequent monitoring. If patients are on IV therapy, especially during the intensive phase, there are steps that need to be done even prior to initiating the IV therapy. First, we need to get the patient set up with a home healthcare company and then have the patient get a PICC line placement as an outpatient. And then the home healthcare company, they need to approve the antibiotics prior to them initiating them. So that can also place more stress. If they don't get approved, we may have to change our treatment plan. The home healthcare company and nursing staff, once everything is approved, they will see these patients weekly for dressing changes as well as weekly lab draws. We are then in contact with these patients over the phone pretty much weekly at this point to ensure that their labs are all within normal limits and if we need to make any changes. So for example, the labs will help us monitor for any renal dysfunction. As well, if patients are on IV amikacin, it does allow us to obtain amikacin peak and amikacin trough levels. Amikacin peak levels, it's very important for you to be aware and to also notify the home infusion company, should be drawn 1 hour after infusion of amikacin is complete. The peak aim is 50 to 60, but this could change based on comorbidities of the specific patient. So there is some variability here. And then the trough level, which we do weekly, is drawn 30 minutes prior to dosing. And we want these results to be less than 1, meaning not detectable at this time. It's also important to monitor any side effects patients may experience while on antibiotic therapy. The GI side effects are the main side effects while patients are on IV therapy. Providers could potentially prescribe anti-nausea medications such as Zofran. However, you'll need to proceed with caution while doing this, as many of the antibiotics could prolong the QTC interval, so regular monitoring of EKGs is necessary. In addition, while on IV amikacin, regular audiogram monitoring is also important. And if a patient's on an antibiotic such as linezolid, as we've mentioned prior, these patients would need regular eye exams as linezolid could cause optic neuritis. It's important to remember that the key to success on having patients on an antibiotic regimen as intense as those with M. abscessus is open communication with the patient and following them very closely clinically. This can be done through a combination of ways, including in-person and or video visits, or even through regular messaging and phone calls. Educating patients on letting us know about any new side effects that they have as early as possible is key, as we want to know early on before they have any permanent issues because of the toxicities of the medications.
Wonderful, Amy. It is very, very complicated taking care of these patients, but it is very rewarding when we're able to help improve their symptoms and make them better. So I hope we've been helpful to those listening to give you some pointers on how to assess patients and treat them who have recalcitrant or resistant MAC or M. abscessus, definitely the more difficult patients to treat in this group. I want to thank my guest, Amy Springer, for joining me in today's discussion. It was great speaking with you today, Amy, and I want to thank everyone for listening to Chest Pulse.